Thank you, Dr. Shishabor. Thank you all again for the opportunity to be here and talk about a challenging case which we could not cross antegrade. We subtitled this Not Pretty But Pretty, and we'll see why as we get into some of the pictures. So we start with our clinical history as always. The patient's an 82-year-old female, came in with progressive rest pain in the right lower extremity, as well as non-healing wounds, the tip of the fifth digit as well as on the lateral heel. Unfortunately, it's not that simple because this is also an individual who had a non-healing wound concurrently on the left lower extremity, more severe at the time. She underwent a femoral popliteal bypass that was complicated, unfortunately, by a severe case of necrotizing fasciitis that led to a left lower extremity above knee amputation, secondary to an overwhelming infection. She lost the leg above the knee and also has a vascularized but certainly not healing wound all the way extending up into the thigh and groin of the left leg. This leaves her completely dependent on this right lower extremity for her transfers and radials, and that foot is an exquisite severe rest pain. I also was not really even plan B, so after the surgical procedure, she was seen by another operator with regards to the right lower extremity foot wound 2 months prior. She had an angiogram and an endovascular attempt by that person, and limited documentation used the terms occluded popliteal, obliterated trifurcation, and failed reentry with pioneer of the tibia perineal trunk. And so our plan, we did a duplex of the lower extremity. The CFA was open with a triphasic waveform, demonstrative likely of good inflow. And then there's severe popliteal disease that we will see. So the goal was to go antegrade in the right CFA, and fortune favors the brave as we see what we'll see. So I show you above and below, and then we'll show you what's in the middle next. But up top, the proximal SFA to mid SFA was patent. Down below, that perineal is patent. There's a little bit of a dorsalis pedis versus a collateral down at the foot. And unfortunately, in the middle is where things get complicated. So flow coming into the proximal popliteal, a little bit of a stump or a beak, a large geniculate collateral coming down around the knee. And the question with regards to what reconstitutes, whether that's distal popliteal, that's tiny, whether that's small vessel arching out, almost retroflexed, but at a 90-degree angle at best, whether that was the AT versus a collateral, and if that's our TP trunk extending down into that perineal with an occluded posterior tibial at the ostia. So, staring at this from afar, again, reminding you that another attempt at this had been performed endovascularly with a failed attempt at re-entering with a Pioneer device. The thought was, well, let's see what happens antegrade, but of course we're not planning on being able to successfully cross this antegrade. We used a 014 nitrix down to bring a Viance microcatheter. If you're not familiar with that catheter, it's similar to a cross-boss catheter, meant to stay true luminal. It's also a small catheter, so 0.037 in diameter for the actual catheter. We targeted that beak to see where we would go. Sure enough, we actually, quote-unquote, flew, popped through that proximal cap, but then did not re-enter, actually came quite close to that TP trunk, raising the suspicion that this was the same territory which a previous operator had gotten to when they attempt to re-enter. We certainly weren't going to try the same thing with an opportunity at the DP for retrograde crossing. There was a question about, well, with a passage through that first level of occlusion, should we think about doing what might be even considered an investment procedure proximally to see if we can open up part of that popliteal to see what flow looked like? We did that, so we didn't go all the way down, but we took a 2.0, tiny, undersized nanocross proximally to better visualize what the true path of the popliteal was. That gave us some insight to the pathway of the popliteal, also made a little more robust that collateral flow distally, but again, we have yet to connect the dots. Therefore, we took a look down at the foot. That perineal is the surviving dominant vessel. It's the inline flow to the foot. There's no reconstitution of the PT, but we did have this dorsalis pedis. The opportunity to target that DP through the AT was one we chose because it allowed us to avoid actually accessing the deep perineal, also allowed us to avoid accessing and occluding the one vessel runoff to the foot. So micropuncture access to that BT, V18 up through a CXI-018 microcatheter. And so we got a wire from above, and we still had our wire down from below, and we're able to start connecting the dots. So that wire into the AT came all the way up to that level of reconstitution of what we thought maybe was the AT. Now we think it was a little more. We re-entered that actually with the Miracle 12, and that led us to get a wire actually coming up through the dorsalis pedis into the AT, into that channel we'd created with a nanocross up from the popliteal. We then externalized through our antegrade sheath, giving us the microcatheter itself coming up through the CFA, flipped the catheter off the nitrix wire, brought it down into the AT, allowing us to put the antegrade nitrix in and remove our AT access with manual pressure before opening inline flow. We then started with undersized balloon angioplasty all the way down. Again, we weren't sure if proximally we were in a plane we created, a plane someone else created, or a native popliteal, so we started small. This gave us some inline flow, but again, dissection at the P3 segment, AT outflow distal to where we'd come up. Again, we hadn't ballooned that whole territory yet, was still occluded. Also a suggestion of decreased flow within the TP trunk, certainly not pretty, not perfect. We then did 2.5 by 40 millimeter chocolate angioplasty of the AT, coming all the way back up. This gave us an AT, but we still had that P3 dissection, but we also had the perineal now occluded, which was our one line of inline flow. Whether we dissected a plane, whether we shifted that plane, whether we moved plaque over to the perineal, we had an open AT now, but we had no perineal. So we worked to move quickly before we lost that outflow, bringing an 014 nitrix through a trailblazer, buddy wiring down into the perineal, actually re-entering, probably through something similar to a star, subintimal tract and re-entry down into the perineal, and then we chocolated that perineal coming back to the ostia. We then did a popliteal, a 40 by 120 chocolate. Again, tiny woman, staying small, not sure what planes we were in. And so we started with this. We then, at the distal popliteal segment, had this with dissection, and then distally at the level of the trifurcation, multiple overlapping, almost spiraling planes. Again, I could take some credit for these planes, likely not all of the credit for these planes, having been not the first person in there, not the one that tried to re-enter. So, not pretty, but we did have inline flow. So looking at that popliteal, none of which was previously present, we had robust flow getting into that TP trunk as well as that anterior tibial, not flow limiting, but with a long occlusion previously now open. So we talked about options. We certainly weren't going to put coronary stents in a bifurcation strategy at the trifurcation. We could have ballooned larger, but we weren't sure exactly which of these planes we'd created, what was true, what was not. We ended up saying, okay, this is what our picture looks like. So we have inline flow coming down the perineal into the AT, and then at the level of the foot, as it plays, you'll actually see that we now have inline flow to that perineal with robust flow, including flow down to the ankle level at that AT. And the thought was, well, this was a retrograde, maybe investment procedure, but let's see how she does clinically after all, because that's more important. We can always come back and we can do more work as we need to. But then thankfully, with that established flow, things went well clinically. So we started here on July 5th with that wound, that redness. We obviously followed her closely. So we saw her days later after the procedure. She had a little bit of reperfusion edema after inline flow. A week later, all of a sudden, a couple weeks later, that wound was actually starting to close up. A month later, all of a sudden, that wound was completely healed. And then a couple months later, all of a sudden, that foot looked beautiful. And so again, going through the thoughts and the process, certainly not a perfect, far from perfect angiographic result, but one in which after multiple procedures in a woman who'd already lost her left leg, we managed to establish inline flow. We dealt with the complexities of a quote-unquote obliterated trifurcation via retrograde tibiopedal access. We dealt with the complexities of repeated intervention after failed antegrade attempts. And we had pretty much near immediate resolution of breast pain and most importantly, wound healing. And again, we also demonstrate that not just the index procedure, but also close clinical follow-up is extremely important for this patient. So, thank you.